Hello everyone, this is Dr. Susan here. I'm a liver transplant anesthetist and intensivist. Today I will be talking about an important topic which is often ignored or neglected, but I'm pretty sure many of the anesthetists and the intensivists will come across this clinical situation when they start practicing. So, and this holds an important part because it just not benefit one patient, it benefits more than 2 or 3 patients. And the appropriate management is very important in getting the deserved outcomes from these patients. So yes, today I will be talking about brain dead donors and their management both in the ICUs and the operation theater. So the topics of discussion today will be definition of brain death, determination of brain death, and the declaration process around it, the pathophysiology behind it, and the management of these donors in the ICU and in the intraoperative period. So coming to the definition, the earliest definition for brain death was given by an ad hoc committee headed by an anesthesiologist in 1968, and this is called the Harvard criteria. And this included the following concepts of unreceptivity and unresponsivity, no movements of breathing, no reflexes, and a flat electroencephalogram. Later on, these definitions were modified, and currently the American Academy of Neurology has defined brain death as an irreversible and permanent loss of all functions of the entire brain, including the brainstem. So what are the three essential findings important here are the absence of response to any kind of stimulus, absence of brainstem reflexes, and the presence of apnea. So how do we determine brain death? So there are 3 steps. So first you need to establish the etiology behind the brain death. Either it will usually be trauma or following a cerebrovascular accident. Then we need to exclude potentially reversible causes that produce signs similar to brain death. Then the most important point is the demonstration of clinical signs of brain death, including coma, brainstem areflexia, and apnea, which persist for an appropriate period of observation. So what are the confounding factors that we need to exclude before we proceed for the test for brain death? So you need to exclude shock or hypotension, presence of hypothermia as recorded by a core temperature of less than 32 degrees Celsius, exclusion of brainstem encephalitis, and other infectious causes and inflammatory causes such as Guillain-Barré syndrome, encephalopathies due to various causes such as metabolic sepsis and other related features, severe hypophosphatemia, endocrine disorders such as hyperosmolar hyperglycemic state, severe hypothyroidism, drugs known to alter neurological and neuromuscular functions. So here our anesthetic agents and the muscle relaxants will come into place, and we need to make sure that the half-life of these agents are exceeded before we proceed for brainstem testing. So what are the tests for the determination of the brain death? So first we look for the tests for cranial reflexes. So what are the reflexes that will be tested? So we test for the pupillary reflex. So this is a response to direct and consensual light, which will be elicited as a constriction of the pupils. So here we are essentially looking at cranial nerves 2 and 3. And the corneal reflex, which is the blink response to an object, external object. So here we are looking at nerves 5 and 7. Oculocephalic reflex, famously called as the doll's eye movement. Here, the movement of the eyes towards the same direction as the head rotation is the expected response in brainstem dysfunction. So the nerves tested here are 3, 6, and 8. Then you do the oculovestibular reflex, which is called as the caloric test. Here, the external auditory canal will be irrigated with cold water, and we look for deviation of the eyes. So there will be no deviation of eyes when brainstem dysfunction. And here the nerves tested are again 3, 6, and 8. Cough and gag reflexes test the nerves 9 and 10. So here a wooden spatula to stimulate the posterior pharyngeal wall to elicit gag reflex, or a soft suction catheter through the endotracheal tube or a tract tube to elicit the cough reflexes. These 2 reflexes will be lost in a brainstem, brain dead donor. So what is the confirmatory test for brain death? So that would be your apnea test. So apnea test is the confirmatory test. Here, the absence of respiratory drive to hypercarbia by means of an apnea is tested. So two tests should be performed by different medical practitioners 6 hours apart to test positive for brain death. So how do we do it? So first you need to pre-oxygenate the patient. So pre-oxygenate for 15 minutes with 100% oxygen and make sure you have an arterial PO2 of more than or equal to 200 mmHg before conducting this test. So even before starting the apnea test, we need to make sure the confounding factors are excluded and appropriate temperature is maintained, positive fluid balance is available, and the PCO2 levels are normal or within or around 40 mmHg, and you have a normal PO2. So then you do a baseline ABG. So then the patient will be disconnected from a ventilator and a repeat arterial blood gas will be performed after 10 minutes. So during the disconnection period, either oxygen can be supplied through a soft catheter, suction catheter connected, put down the ETT with 4 to 6 liters, or you can just connect it to a vein circuit for apneic oxygenation. In case of any arrhythmias or hypertension or desaturation during this disconnection period, then we will have to abandon the apnea test and resume mechanical ventilation. So about apnea test, if there is hypotension, if there is presence of cardiac arrhythmias, or if there is desaturation, and then we can repeat the apnea test after 3 hours following stabilization. So how do we interpret the results of the apnea test? So if there is, if the test will be considered as positive, if the respiratory movements are absent after reaching a PCO2 of more than 60 mmHg or a 20 mm increase from the normal baseline. So that means that you have achieved apnea and hypercarbia and your brainstem has not responded to it by producing respiratory movements. And the test is considered as negative if there are respiratory movements present. That means you have a functional brainstem. You can consider it as indeterminate if you are not able to achieve PCO2, or if the PCO2 increases less than 20 mmHg over the baseline. So following a negative result, you can do an ancillary test, which I will be talking about in the following slide, or repeat the apnea test after 24 hours. Again, in case of indeterminate test, you can repeat it after 3 hours. So what are these ancillary tests? Ancillary tests are some tests which we do when you can't perform a apnea test, or if the apnea test is negative or indeterminate. So what are the situations where you cannot perform an ancillary test? When there is you cannot perform an apnea test. When there is facial injury, facial maxillary injury, otorrhea, eye agenesis, where is presence of high cervical cord or thoracic injury, when the PEEP or the high FiO2 requirement is high, which will prevent you from disconnecting the patient from the ventilator, or you cannot perform the complete CNS examination and the family members require reassurance. Also, when there is presence of disagreement between the panel of doctors presenting this, then we go towards ancillary tests. So what are the ancillary tests available? EEG is available, where you elicit bioelectric silence for 30 minutes. Then there are some tests called evoked cerebral potentials, cerebral circulatory testing by means of a transcranial Doppler or a scintigraphy, and CT-MR angiography. These are other tests which are quoted as the ancillary tests, where you consider angiography is considered as the gold standard for utilization in case of a brain dead donor declaration. So how does this declaration process happen? So a brain's death certification team is first formed, which consists of 4 panel of doctors. So this can be registered medical practitioners in charge of the hospital, neurologist or a neurosurgeon, or an authority nominated by the in charge of the hospital, such as a surgeon or a physician, and an anesthetist or an intensivist. Then the physician or the intensivist or the anesthetist treating the deceased person. So these 4 doctors form the team, and this team should not be part of the retrieval or the transplant team. The doctors involved in donor maintenance and the certification should not be in